So I'm going to maintenance my Catalyst 1 machine. So the first thing I'll do, I'll open up the side and pop open this. I'll take out my carousel, which I'll set gently down. Take my IDEX approved alcohol prep pad and wipe around the inside clockwise. And I'll do that until there's no visible residue on the pad. Now I'll get a nice clean swab there. The next thing I'll do is take my carousel. I'll clean the white reference tile, like so. I'll take my optic tissue to dry. Again, an IDEX approved item. Now that that's done, I'll place my carousel gently back into the machine and make sure it stays in place. I'll bring this back down, close the door, and tap done. And I have successfully cleaned my Catalyst 1 machine. I'm going to run a 40x snap ELISA test. So the first thing I'll do, I'll take my whole blood in the EDTA tube and take 3 drops of that and place it into my other tube here. So I'll go 1, 2, 3. The next thing I'll do is take my conjugate and put 4 drops in there. 1, 2, 3, 4. I'll invert it 4 times. I'll take the entire contents of this and place it into my test well there, and I'll wait until the sample runs entirely across the screen. Once it's come entirely across, I will press down snap, set my timer for 8 minutes, and come back with results. Here I am exactly 8 minutes later, and this test indicates a positive Lyme disease, Ehrlichia, and anaplasmosis positive test. Alright, so I'm going to do a fecal flotation here. So the first thing I will do is take about 2 grams of fecal matter to put into my cup here. I'll take my flotation solution, which is the sugar solution, and I'll mix that very thoroughly. I do have my strainer here as well as the cup I'll be using. I will also need a cover slip. Now that my solution has been mixed very well, I will suck it up with my syringe. which I will take and strain through the cup I'll be using for testing. And I will fill it so there's a meniscus on the top of my cup, which you can see right there. I'll place the cover slip on the meniscus, and I'll allow it to sit undisturbed for about 10 to 15 minutes, and I'll come back and put it on a slide to look microscopically. Alright, so back to my fecal flotation. It did sit here for about 15 minutes. I'm going to carefully remove the cover slip and place that onto my microscopic slide. And then I'll take that back to the microscope and place it on at a magnification of 10x. And I'll get it into focus here. And view my entire slide for parasites. And I do not see any parasites or eggs. Alright, so I'm going to do a fecal flotation with centrifuge. So the first thing I'll do is take 2 grams of fecal matter, place it in my cup, and I will mix this with my flotation solution, which is a sugar solution. And this will be mixed thoroughly. Once it's been mixed thoroughly, I will take it and I'm going to strain the emulsion through my tea strainer here, my tea bag. So I have my centrifuge tube, my strainer, which I'll place right over top, and I'll strain it on in, and I will leave a small space at the top. Just about that much up at the top. I will place the cap on it because I do not want a disaster. And then I'll bring it over to my centrifuge. I'll place it in my centrifuge and allow it to spin on fecal for 5 minutes. And I'll be back soon. Fecal flotation with centrifuge. I'm going to go back over to my centrifuge, which did centrifuge for about 5 minutes. I have that here. I'm going to open it up and place a little more solution until a meniscus forms. I'm going to set it down. So like I said, I'll place more solution until a meniscus forms. Now that I have a meniscus, I'll take my cover slip and place it on top. And I'll allow it to sit for 10 to 15 minutes before removing the cover slip and viewing it microscopically. Alright, so the last step of my fecal flotation with centrifuge, I had my tube sit there for about 15 minutes. I'll carefully remove the cover slip. Not spill my solution. Place it onto my microscope slide. And same as before, I will view the entire slide at 10x and look for any eggs. On this slide here, I do not see any parasites or eggs at this point. Alright, so I'm going to do a fecal test via a direct smear here. So the first thing I'm going to do is just place a couple drops of saline onto my slide. And I will take my fecal sample and do about an equal amount of feces onto the slide. Alright, now that I have my feces on the slide, the next thing I'll do is mix it until the solution on my slide is homogeneous. I do believe I just need a little bit more saline. Alright, now that the solution is homogeneous, I will smear the solution to make a thin layer across my slide. And it should be thin enough that I can still read through it. At this point, I'd remove any large pieces of feces, but I do not have any. At this point, I'll take a cover slip to place on top of. Now that I have my cover slip here, I'll bring it over to my microscope. And I'm going to look under the microscope for any parasites or parasite eggs. And on my gross microscopic exam, I do not see any parasites or parasite eggs. Yeah. So I'm going to do a fecal testing using sedimentation. So the first thing I'll do, I'll take about 2 grams of feces from my sample. Which I'll then mix with tap water. I'll mix it up very nicely. I will then take my solution, strain it through a gauze sponge into my centrifuge tube. Draining through my sponge here into the tube. Now I do have it strained all the way through. The next thing I'll do, we'll centrifuge it for about 5 minutes and then allow it to sit undisturbed for a half hour. Bring it over to my centrifuge, which I of course want to make sure is balanced. I'll switch it over to the fecal setting and centrifuge for 5 minutes. And then I'll allow it to sit for 30 minutes and I'll be back. So back to my sedimentation here. I did allow it to centrifuge for 5 minutes and then it sat undisturbed for about 30 minutes. The first thing I'm going to do is pipette the liquid off of the top of the tube without disturbing the sediment down at the bottom. I do want to make sure to get all the liquid out of there. Now that I did that, I will take another pipette and just take a small amount off the top layer of sediment in there. Just a small amount, which I will take and place onto my microscope slide. I will take a cover slip, place on top of my sedimentation, and then I will examine it microscopically. Typically we use 10x, but sometimes we do have to use a 40x. And now that I've examined the entire slide, I'm going to say that I did not see any ova or parasites or eggs on my slide. Alright, so I'm going to do an ear cytology here on my patient Lola. So what I have out in front of me, I do have my cotton tip applicators. I have some sterile water that I did pre-moisten my Q-tips with to take a cytology of. I guess those are for you. And I have my slides which are appropriately labeled. So I'm going to take my moistened Q-tip here and I'm going to go into Miss Lola's ear and I'm going to get down in to the point where the pathology would be and give it a little rub around in there. And then I'm going to take it to the appropriate slide and I'm going to gently roll it across the slide, making sure not to get too much excess debris as well as not slide it across. I'm going to do a gentle roll. And then we'll go to the other ear. Here, look. Same thing. I'll open up her ear. It's okay. Same thing, get down into the ear canal there. Take my swab. And bring it over to my slide and gently roll it across. You found my cookie, huh? And then I'm going to take these to the lab to be stained and evaluated under cytology. Alright, so now I have my cytology in the lab here. I'm going to start by placing it in the first stain.
Plus, he's an only dog. I mean, I do think.
On to the next one. And finally on to the last one. And when I take it out of the last dye, or stain, I'll bring it over and rinse it off. And let it dry. Now that my slide is dry, I will take it to my microscope under the lowest power field.
Yeah, otherwise, yeah, that way nobody's going to be protective of their curve. Yeah.
And on this slide, I see a lot of acellular debris and maybe a few yeast. So talk about fungal testing today. So in terms of indications, traditionally there is a characteristic circular lesion on the animal that does, represent a circle, which is why they do often call it ringworm. 98% of cats and 50 to 70% of dogs, when they have an infection like that, it is due to Microsporum canis. And like I said, it does have the characteristic circular lesion. Another indication of fungal testing is when that circular lesion, if you apply a wood lamp to it and it lights up, that is another indication that it is possibly fungus, and we should do a fungal test. Miss Lola here does have a funny circular lesion. That does indicate that some fungal testing may be necessary. So what I have here, I have my microscopic slide, as well as my clearing solution and my forceps to go ahead and pluck a little bit of her fur. So I'll bring her up, right by her funny little lesion that she has. I'm just going to take and pluck a couple of pieces of fur, just 2 to 3, not very much necessary. Okay, go ahead, keep going. I'm going to place it on my slide and place my clearing solution. I'll place my clearing solution on it. In about 2 to 10 minutes, I will place it underneath my microscope, and at that point, if it is indeed a fungus or fungi that is affecting Miss Lola, we will see some small globular erythrospores. So I'm back at the lab here with my hair that I'm doing for the fungal test. I'm going to apply a cover slip over top and view under the microscope. And what I'm specifically looking for are globular arthrospores attached to the hair shaft. After reviewing my slide, I do not see any arthrospores, so we are going to have to do some further testing to figure out what is causing Lola's circular lesions. Alright, so I'm going to do a skin scrape on my anesthetized patient here. He does have a history of generalized pruritus as well as some pretty nasty skin here. So the first thing I'll do, I'll take a drop of mineral oil and place it onto my slide. I'll take my 10 scalpel blade, which I will dip in the mineral oil. I'll hold with my thumb and forefinger and scrape perpendicularly to the skin. And I'm going to scrape hard enough so a small amount of capillary blood oozes. And now that I'm seeing the capillary blood, I will take my blade here and dip it back into my mineral oil and get all the debris off of it. I'll place a cover slip on top of that and bring it over to the lab to look under the microscope. Alright, so I have my skin scrape slide here that I'm going to place under my 4X field, and I'll scan the whole slide for any presence of ectoparasites. And I do not see any parasites on my slide.
So this is Trinity. She is a 7-year-old intact female Persian cat with a history of chronic small bowel diarrhea. She was seen here last night. Subsequently, after leaving here, prolapsed her rectum. She went to the emergency clinic, and they elected to euthanize rather than repair the prolapse. So the owner, since she's a breeder, she's very motivated to find out, get a definitive diagnosis as to what caused the chronic diarrhea. So generally what I would do is a brief external exam. Not a lot different than a routine physical exam, except obviously we're not going to listen to the heart and lungs. Oral exam, just look at the eyes. I always just make an assessment of body condition. This cat is thin. I would call her a 3 of 9 body condition score, which is expected given the fact that she's got chronic diarrhea. For unexplained deaths, we would always assess for signs of trauma, palpating for fractures, palpating for, we always look at the nails, look for evidence of trauma in the nails, or is there fur from another animal on it, that it could be a bite wound that's not obvious. We'll check for external parasites, which I don't see any of them here. So the physical exam, externally appears pretty normal, except for the thin body condition. So we're gonna make a midline incision, completely up. I say the external physical exam was normal. I failed to note the prolapse rectum, which was the reason for the euthanasia. I typically would go right on or about midline.
Dr. Kelly did use a 10-blade scalpel to cut open, and now you're using Mayo scissors?
Yep. What we'll do, we'll cut right up through the diaphragm, and then up through the sternum. So as we look grossly, in the abdomen, liver appears normal. Gallbladder may be slightly enlarged, but full of what appears to be normal fluid. The diaphragm is intact. Stomach is distended with gas. Appears to have no food in it. Spleen appears grossly normal. Pancreas here appears normal as well. So pancreas is going to be in that first loop of bowel associated with the duodenum here. This is one branch of the pancreas, this is the other. And then we're going to run the bowel, so leaving the stomach. That's just staining from that piece of bowel being up against the gallbladder. See, same thing on the liver. Yep. So that's a post-mortem change. One of the biggest challenges with a post-mortem is, for me, that don't do them a lot, is differentiating between. So here is her right kidney. Here's her left kidney. Left kidney sits back further. Right kidney is a little further, more anterior, cranial. That appears normal. So go back a little further. See the bladder, that's normal. Here's a cat's uterus, ovary, the other ovary here. The aorta coming down, that'll bifurcate right back here to the femoral arteries. Reader from the kidney. So really the only gross abnormality I see on the physical exam here is pretty thickened bowel, which makes sense given that we get a chronic diarrhea, and I suspect that that's where we'll find our diagnosis on histopathology. If we come up into the chest, here's the heart. Say normal in size and proportionality. I'll get a diagnosis. So typically when I take the biopsies, post-mortem, I'm going to take a full thickness of duodenum, ileum, jejunum, and cecum. And I just take full thickness. So that's jejunum.
And I did label these jars accordingly.
Probably use smaller jars too, because I'm going to take the vital samples. But all right, that's my entire lymph node. So I think we would be completed. I think we're gonna get our answer right there. I don't know if you want to take a feel of it, feel how thick it is. I mean, normally it should be pretty thin. Very good.
That completes our necropsy. So I'm going to talk about rabies suspect handling today. Who can handle a suspect? Clinicians and technicians who are pre-immunized against rabies with a serum titer greater than 1 to 5 are able to handle a rabies suspect. The person preparing the animal must wear double gloves, a protective mask, and goggles. The specimen that needs to be submitted is the head. The head should be double bagged and placed in a refrigerated container with ice packs. The sample should not be frozen. In our state of New Hampshire, we do contact the local law enforcement who transport the sample down as soon as possible to the lab. The specimen is accompanied by a completed rabies questionnaire form. The remainder of the body is disposed via cremation. So there's 4 stages of canine estrus here. We have anestrus, proestrus, estrus, and diestrus. In terms of what we'll see on the microscope, for anestrus, we will see we'll see mostly intermediate and parabasal cells. We will occasionally see some neutrophils and red blood cells. They may or may not be there. Moving on to proestrus, we'll have a mixture of parabasal, intermediate, and superficial epithelial cells. There'll be a gradual shift towards all superficial cells. Red blood cells are present usually in large numbers, and neutrophils are also commonly observed. There's usually also a large number of bacteria. Moving forward to estrus, the predominance of superficial cells are nearly all anuclear at this point. Superficial cells are always keratinized or nearly all keratinized. There's often bacteria that are attached to the superficial cells. Neutrophils generally are absent, and there are very minimal erythrocytes. Diestrus will see a decline in the number of superficial cells and a reappearance of the intermediate and parabasal cells. There's usually a lot of cytologic debris as well. It's also, it's noted that diestrus and anestrus are very hard to differentiate between, and those are the 4 stages. A vaginal cytology here on Miss Lola. I have everything I need here, including my Q-tips as well as my slides. My stain is over in the lab. I have my intact bitch here. So the first thing I'll do, I will wash her vulva. After her vulva has been washed, I will moisten my Q-tips with saline. So I'm going to go in at a relatively steep angle, and once I've advanced in a little bit more, I'll go to a 45-degree angle and advance 4 to 6 inches in. So going in at a steep angle here, and then rotating to 45. Going inward. Now that I'm in far enough towards the vagina, I'll just rotate my Q-tip about 2 to 3 times here. And then I'll pull out. She's all set. I'll go over to my slide here and gently roll it, being careful not to slide. And roll it on 2 different parallel slides. So now my vaginal cytology is here in the lab, so I am going to stain it using my red stain first, dipping 5 to 10 times. Moving over to my blue stain, 5 to 10 times. Which will then be rinsed gently. So after reviewing my slide here, I can safely say that what I'm seeing is primarily intermediate and paranasal cells, meaning that this bitch is in particularly anestrus at this point. That combined with no behavioral changes does indicate that she is in anestrus. Alright, so I'm going to do a cross-match test here. So the first thing I did, I drew blood from both my recipient and my donor. I separated it into a serum separator tube as well as an EDTA tube. The next thing I did, I let my sample clot and spun it down and separated the serum into plain red top tubes with no additives. With my EDTA, I spun it down in my centrifuge and I still have both parts of it there. So what I will do to make my erythrocyte suspension, I will decant the plasma off the top of these tubes and down to just packed erythrocytes in the bottom of my. I have my 12 by 75 millimeter disposable glass test tube. I'm going to take 1 to 2 drops of my erythrocytes. So here I go. Get rid of that bubble. So I'm down to 1, 2 drops of whole blood or erythrocytes. And the next thing I'll do is I'll fill up the rest of my tube with normal saline solution, which is 0.9%. So I'll fill up the tube. This tube will be gently mixed. I'll place it into my centrifuge. Now that I've done my donor, I will take my recipient with a new pipette and repeat the procedure. I will gently mix, place into my centrifuge, which I'll set at 3,400 RPMs. And I'll just centrifuge for 1 minute, and I'll be back to continue to wash. So now that my erythrocyte suspension is spun down for a minute at 3,400 RPMs, I will go ahead and decant the supernet. I'll decant it all the way down to my packed red blood cells at the bottom. This is my recipient. I'll do the same thing with my donor using a new pipette. So now that I've got rid of that, I will repeat the procedure by refilling my tube with normal saline solution. It will go back into the centrifuge and spin again for 1 minute at 3,400 RPMs. I will repeat this procedure 1 additional time until my supernet is completely clear and colorless, and that will indicate that my erythrocytes have been thoroughly washed. Alright, so now that I've washed my erythrocytes twice, you can see that they are thoroughly washed by my supernet is completely clear and colorless with my red blood cells down at the bottom. So just as before, I will decant the supernet. So now that I have just my red blood cells down at the bottom, to take my recipient supernet off the top. So down at the bottom I have just my packed erythrocytes. The next thing I'm going to do is make a suspension. What I'll do is I'm going to make a 2% erythrocyte suspension by taking 0.02 of my erythrocytes, which I'll place in my new labeled test tube. And what I'll do is I'll take my 0.98 mLs of saline and place them into my test tube, leaving me with my 2% erythrocyte solution for my recipient. It is labeled accordingly. I'll repeat this procedure for my donor. Now I have my donor's 2% erythrocyte suspension. So to do my major cross match here, the first thing I'll do, I'm going to take 2 drops of my recipient serum. 1, 2. And then I'm going to take 2 drops of my donor cell suspension. And I'll mix this gently. And then the next thing I'll do is make my minor cross match. So my minor cross match, I'm going to take 2 drops of the donor serum. 1, 2 drops. 2 drops of my recipient's erythrocyte suspension. Now I have both my major and minor cross match. I'm going to set up 2 controls, and by doing that I'm going to take the recipient serum and recipient's erythrocyte suspension and mix 2 drops of each in a labeled tube. So I'll start with my recipient here. So 2 drops of recipient's erythrocyte suspension, as well as 2 drops of my recipient serum for my control. I'll set up my other control for my donor. I'll take my donor serum. Just 2 drops of my donor serum. 1, 2, and 2 drops of my donor's erythrocyte suspension. So now I have both my major and minor crossmatch as well as my 2 controls. So all my tubes are in a rack here, so I am going to shake gently to mix them. Then I'm going to let them incubate for 30 seconds at room temperature. It's incubated for 30 seconds at room temperature. I'll place them all in the centrifuge, which I will spin at 3,400 RPMs for 1 minute. So now all my tubes have come out of the centrifuge. They were all centrifuged at 3,400 RPMs for 1 minute. So looking at my control here, there is no hemolysis noted. Both controls, they look great. Over to my major cross match. There is no hemolysis noted there either. Down to my minor cross match, which same result. There is no hemolysis noted. So because I did not see any, I will verify under a microscope. I'm going to take a drop small drop and place it onto my microscope slide. So this is my major cross match, which I will label. And then I'll take my minor cross match, and again take a small drop, place it onto my slide. And I'll bring these over to the microscope on my lowest power field and examine for any microscopic changes. And on this slide here, which is my major cross match, I do not see any agglutination. Moving over to my minor cross match, I will do the same thing, placing it on the lowest power field. And on my minor cross match, I don't see any agglutination either. So after doing my cross-matching here, I can safely say that I do have a donor and recipient that are compatible for each other.